Well, I've lived in Texas all of my life except for the year that I did my residency in colorectal surgery in Grand Rapids, Michigan. My interest in colorectal surgery occurred during, I guess, the third and fourth year of my general surgery residency. I, like many people, wanted to be a heart surgeon and after a year or so changed my mind about that. And my decision to become a colorectal surgeon was based on a mentor, as I think many of the people that I've encountered have been influenced by one or more people who did the stuff that colorectal surgeons do so much better than the general surgeons. And watching him do that was very impressive to me and sort of made me want to grow up and be like him.
And for you, who was that mentor?
That was Jim Hampton.
And what was it about him? And
you know, he was the first really trained colorectal surgeon in Houston. He had trained with Dr. Bacon in Philadelphia, and he was a master surgeon. He was ambidextrous, and that inspired me to try to become ambidextrous. He really operated as well with his right hand as his left hand. And so I asked him one day, how did he do that? And he told me that when he was a resident, he started eating with his non-dominant hand. And so I started eating with my non-dominant hand, and it's really worked out very well, particularly for anorectal surgery and working with residents. Being able to work with either hand has been a big help.
And tell us a little bit about where colorectal surgery was when you started. What was the state of the art?
Colorectal surgery was just sort of escaping from proctology at that point in time. In fact, I believe that the name of the society changed from the American Proctologic to the American Society of Colorectal Surgery either in 1974 or 1975. I'm right there. So, and I think that the other people in Houston at that point in time were all anorectal surgeons who had then started doing some colon surgery that didn't necessarily do it very well. And now, of course, it's evolved to where I'm afraid that that we're starting to lose our roots in anorectal surgery. Looking at this meeting, it seems to me that the focus is all on colon surgery and laparoscopy and that sort of thing, with a very minimal emphasis now on anorectal surgery. And I think that I'm sorry that I see that happening. I think that it's great that we do good colon surgery, but I think the other area where we have great expertise is in anorectal surgery, and we help a lot of people with that, and I don't want us to lose our focus there.
And in terms of the diseases we take care of, how have you seen a change from what's been some of the major changes from when you started, in terms of how we care for people, in terms of when you started to now?
Well, you know, when I was president of the society, my presidential address was a lifetime of learning, was the title of it, and I sort of chronicled the things that had changed since I finished my general surgery residency up to 2001, or when I gave the address. And I mean, you know, the changes are phenomenal. We didn't have any staplers when I started. We certainly didn't do laparoscopy. CT scans had not yet come along. We still actually had to examine patients and look at old X-rays and barium enemas and those kinds of things. Colonoscopy was in its infancy. I think I did 10 colonoscopic examinations as a resident in colorectal surgery. Now our residents do 300 or 400 with complicated polyps and those sorts of things. The ilioanal reservoir procedure certainly had not come along. We did do some pull-throughs, but we did them the old way where you pull the piece of bowel out and sutured it to the buttock and let it auto-anastomose and then go back 2 weeks later and cut the thing off. You know, the changes are phenomenal, and certainly I think it's critical that everybody continue to learn the new techniques so that they don't become dinosaurs. I hope I'm yet not a dinosaur.
And where do you see where do you see the future in terms of the care of patients with colorectal problems?
Not sure I have my crystal ball is that clear. You know, we have, I think that most of the things that we take care of, we do better now than we did 30 or 40 years ago. I think that a lot of the anal-rectal surgery is better. I'm not sure that all of the new technologies, the stapling things for anal-rectal surgery have necessarily been all positive. Certainly, I think our concept of the management of diverticular disease has gone through several iterations during my professional lifetime. I was just on the tail end of getting rid of the 3-stage colon resection for diverticulitis. And now I have to spend a lot of time talking to patients and to referring doctors to convince them that the 2 strikes and you're out rule is no longer the right thing to do. It was fascinating a couple of years ago to hear Alan Marr from Australia go back and figure out that paper of Park where he had been misquoted for 40 years with the data about the third time people got hospitalized.
And I know you've been interested in surgical education for a long time. So what was that like in terms of educating colorectal residents when you started, and how have you been involved, and what do you see now?
So I became a program director in 1985 or 6, and did that for 20 years, maybe a little bit, 22 years, and then finally handed that off. It was certainly much more free form then. It was, I think that a lot of training is still preceptor based, in that you work with 1 or 2 people at a time and teach them what you can, and vice versa. The board examinations have certainly changed dramatically from when I took the boards to what we currently do. I had the opportunity to be the examination chair of the board for 3 or 4 years during my tenure on the American Board of Colorectal Surgery. And we started at that point in time doing some of the psychometric analysis of the questions to see whether questions were valid or not, whether our examination was valid or not. Now the examination has become more and more standardized to the point of it now being given in the written examination being given in multiple centers on the testing machines and so forth. The oral examination has also become much more standardized. But I think still the training in colorectal surgery is a colorectal surgeon who wants to train residents, works with a resident, and imparts some or a lot of their knowledge and skills.
So, and how many programs, what's the change in the number of programs from when you started to now?
I think there were about 25 programs when I started, and I think we're now up to 70 or something like that, and the number of trainees is also more than doubled. The quality of people coming into colorectal surgery has just gone through the ceiling. You know, we interview probably 30 people for the 4 slots that we have in our training program, and I think the top 25 of those 30 would all be very good residents in the program. I'm not sure that today I could get into a colorectal residency, but
yeah, you're not the only one who feels that. So I know you've also been involved with, in addition to our organization, with the American College of Surgeons. And can you tell me a little bit about that involvement and what you see as the role of the specialty societies versus the college?
Okay. Well, the college kind of became my second career in medical associations and that sort of thing. When I was either president or sometime in the late 1900s, was appointed to the advisory council for colorectal surgery through the college, and then became chairman of that, and then things just kind of evolved. I became a governor of the college, and then 9 years ago was elected as a regent of the American College of Surgeons, and my term as a regent will end this coming October, the end of 9 years, which has been really a wonderful thing for me, and hopefully for colorectal surgery. I was the first designated colorectal surgeon on the Board of Regents. Robin McLeod went on the board a year ahead of me, and I was surprised then when they called me and said that I was to be the colorectal surgeon. I said, well, Robin is already there, and it was explained to me, you know, there's a little niche for everybody, and they said that actually Robin was a female Canadian, so she wasn't a designated colorectal surgeon. But, you know, I think that the college would like to be and does a pretty good job of being an umbrella organization for not only general surgery but the surgical specialties as well. Nobody, I think, represents the surgical specialties as well as their specialty organization. Nobody cares about colorectal surgeons as much as the American Society of Colorectal Surgeons. But having said that, the college has the ability to do a lot of things that the specialty societies can't do, and one of the big areas has been in the area of advocacy or lobbying, and I think that people ask me, well, it doesn't look to me like they've accomplished anything for me, but what we do is we keep things from getting worse, and I've been fairly involved with the advocacy activities at the college as well. So, but I think that there's very much a place for both the specialty organizations and the college, and I think trying to draw the two as close as possible, because, you know, we're out there against people that are not necessarily our friends, and so the Colorectal Society provides wonderful educational opportunities for our members, but I don't think that it's able to do some of these other things that the college is able to do.
So, what would you say has been the most rewarding part of your career in colorectal surgery?
I think the most rewarding, well, I think there are two things. One, I have loved practicing colorectal surgery. I tell people that after 38 years as a colorectal surgeon, I still get up every morning looking forward to going to work. And I think if you can get a job like that, things have been good for you. So I find the patient care extraordinarily satisfying. You know, not always. Sometimes dealing with patients is not totally rewarding, but day in and day out, it's very satisfying, very rewarding. And the combination of that and teaching residents, we've now graduated 112 residents in colorectal surgery from our program. And I've told people that training residents is a little bit like having a whole bunch of children that you don't have financial responsibility for. So all of that that works very well, and for me has been extremely satisfying. The other thing in sort of organized colorectal surgery that I really found rewarding was the time that I spent on the American Board of Colorectal Surgery. I've been fortunate enough to do a lot of stuff in the Colorectal Society. I was on the RRC, the board, and the stuff now with the American College of Surgeons. But I think of all of those things, that the board was probably the part that I felt like I did the most to maybe make a difference, trying to do something to differentiate the people that should be certified from the people that shouldn't, and so I think that was probably the most satisfying part of my medical organizational stuff.
Was there a lot of resistance to that? Or was it to trying to make it more discriminating about separating out the competent from the incompetent, or was that generally just they were looking for somebody to do the work?
Well, I didn't ever run into very much resistance. I think that certainly the people that were on the board all felt pretty much the same way, that was our obligation to be able to do some sort of differentiation between the quote competent and the less than competent. So words change now. We did everything we could not to use the term certifying competence, and now the terminology's all changed around, and now we're all into certifying competency. So, but I guess what goes around comes around.
Is there something you'd particularly like to see or your hopes for the future for colorectal surgery?
It's been really wonderful to, I think, see the status of our specialty increase over the years. Going from being proctologists, which is what people still occasionally call me, to being, I think, respected specialists that take care of very complicated disease, and now are involved in the vast majority of training programs in general surgery in the United States. More and more universities, in fact, I think the majority of universities now have one or more colorectal surgeons on their faculty. So that's been very satisfying to see that development occur, and certainly I think the improvement in the quality of the people that we're turning out compared to a few years ago. I remember one of the committees that I headed at the ASCRS was the residence committee, and what we did was we would have a cocktail party at the ACS meeting and try to interest people in being colorectal surgeons, because at that point in time not all of the slots were being filled, and now we have probably twice as many applicants as we have slots. So the increased stature of our society and specialty has been very pleasing to me to see.